for several months now, and he's had wax issues in the past. He's also had grommets fitted in the past. So grommets are ventilation tubes that are inserted through the eardrum. And the reason for that is behind your eardrum, we have what we call the middle ear, and the middle ear should be full of air. And there's a tube at the back of the eardrum called the eustachian tube that connects to the back of the nasopharynx, and that eustachian tube is the pressure equalizer in your ear, and it's also a drain pipe, so any fluid that accumulates behind your eardrum in the middle ear can drain away. Sometimes, however, that eustachian tube can get blocked and become dysfunctional, and it typically happens at the back of the nose. When that eustachian tube is blocked, there's no air behind the eardrum, it creates a vacuum. And when there's a vacuum and no air behind the eardrum, so in the middle ear, all the cells in the middle ear start leaking out fluid into the middle ear. And that fluid can generally drain away out of the eustachian tube, but since it's blocked, it's like a blocked drain pipe, so that fluid accumulates, and we call that middle ear effusion. Eventually that fluid can become infected and very thick, viscous in consistency, and we call that glue ear. So this patient had glue ear in the past, and so the ENT surgeon used a scalpel, pierced through the eardrum and suctioned out all the glue ear, all the fluid behind the eardrum. And to prevent the fluid building up again, because that eustachian tube is still blocked, they then inserted what we call a grommet. So that's a ventilation tube, so air can enter the middle ear via the outer ear canal as opposed to the back of the nose via the eustachian tube. I just thought I'll explain that, and the reason for that is because we're working on the patient's left ear in the moment, but when we move over to the right side, which is a bit more of a complex procedure, you will actually see the patient has got glue ear, and we diagnosed that today, yesterday, using a pressure test called tympanometry. When you've got fluid behind the eardrum doesn't vibrate, and we've got a piece of equipment called a tympanometer where we can pump air into the ear canal and assess indirectly if there is fluid behind there. We can measure the mobility of the eardrum in some respects, and this patient's eardrum was actually bulged, so there was a lot of fluid behind the eardrum which can potentially perforate and come through the eardrum, because eventually that fluid has to go somewhere. If it can't drain out of the eustachian tube and it's collecting in the middle ear, it can puncture and rupture his eardrum. Just go back to the video, sorry, I just thought I'll explain that because I know sometimes a lot of viewers ask questions about certain conditions, so I thought it was a good opportunity to talk about glue ear and eustachian tube dysfunction. You can see the wax is very sticky and dense, a very dense consistency, and it's slightly matted. It's also adhered to the ear canal wall, so the skin that coats the ear canal also adheres to the wax, and it acts like a double-sided sticky tape. It's very difficult to remove that wax because we have to really loosen those skin adhesions. With this type of wax, just through my own experience, sometimes you could put drops in, but I don't find drops always as effective with very dry and dense wax like this. So just thought, let's just persevere with the suction probe at the moment without using any drops. And sometimes with this dense piece of wax, if you've loosened it enough, so we can see the wax is quite loose there laterally, but the wax further in the ear, which obviously you can't see, there's still quite a few skin adhesions. You can see that on the right hand side, you can see the skin, the white coating. So I've loosened the dead skin more laterally towards the ear canal entrance, but medially it's still there. You can see all that dead skin, that white keratin, that's all the skin adhesions. You can see just right at the back on the canal wall, you can still see there's some skin adhesions there, very tough skin adhesions. But I've made the wax mobile, so we provide a bit of mobility here, so which then frees me up to use other instruments trying to get in behind the wax, and you'll see that in a moment. I think I'm going to be going in with an ear hook. I think just now. There we are. So because we've made a space, an opening, it's a lot easier using these types of instruments, so ear hooks and Jobson horns, deeper in the ear. If that wax is fully occluding, having to kind of insert it kind of through the canal, and the wax, if we come in contact with the bony part of the ear canal, so the inner 2/3 of the ear canal is made up of bone and a very thin, delicate layer of skin, approximately 0.1 millimeters. So it's a very sensitive part of the ear. Whereas the outer third, so the lateral part of the ear canal, is made up of cartilage with some fatty tissue. So it's more malleable. It's got a buffer, and the skin is a lot thicker. It's 1 millimeter. So we always got to be a bit careful. Sometimes I read comments, why don't you use this instrument deep in the ear? Well, there's a good reason, because we don't want to, these patients are all awake, no local anaesthetic, no general anaesthetic. So the hook did help me slice through the wax a bit, and you can see now the wax is coming forwards and it's giving me something to prise onto. So this wax is probably mid part of the canal now. And in a moment, I think I'm going to be using some forceps because I can grip onto something now. Before, the wax was quite cylindrical, it was round, there was nothing really there for me to prise onto. But just by using the hook, I'm now able to use some forceps and crocodile forceps. I've got enough purchase and grip to really wrap around this wax and gently extract it. You can see it's come out in a nice big chunk there. You can see it's been in the ear for a long time. It's quite dark, so it's oxidized. And here's all this skin at the base of the ear canal. And there's still some wax impacted on his tympanic membrane on his eardrum, so we'll get that out in a moment. But again, you've got this really thick layer of skin. And it really is like double-sided tape. It's sticky against the canal wall. It also sticks against the wax. So you're having to almost play a game of tug and war sometimes when you've got this much dead skin in the ear. You can see the skin there, it's kind of actually on the eardrum as well. And it's attached to the underside of the wax that's impacted on the eardrum. So the second ear, the right side, which you'll see in a moment, is a lot more complex and tricky than this side. So it's a bit of a good viewing if you want to watch that. So stay tuned. And again, we're just using the standard Zollner suction probe here. The fine end just wouldn't be strong enough because of all those skin adhesions. And you can see I've got a good suction grip there. Gently wriggling this out of the ear. You can see all that dead keratin, all that skin, the glossy white skin, and some of it's oxidized, so it's gone to a browner color. And there's a skin ribbon there. So we can see the posterior quadrant of the eardrum, which is the back part. I'm just on the roof of the ear canal and on the anterior wall of the ear canal. Just trying to loosen this. I would say it's actually dead skin, not wax. It looks like wax, but it's not. It's dead skin that's oxidized. It almost looks like a piece of plastic. It's got that glossy effect. You can see it's still just stuck to the roof and just peeling that off there. There we go. That was quite a crusty piece of dead skin. So we can see the majority of the tympanic membrane now, probably about 90%. There is some wax still left in the anterior recess, which is on the left-hand side, whilst you're watching. And we've got some dead keratin there still. The dead keratin is coating a part of the ear canal which we call the isthmus. It's a narrowing very deep in the ear canal, probably between 0.5 and 1 centimeters away from the eardrum. And I said the skin is not infected here, but because it's easily coming away, we're just removing that. We're not going to try and be too fancy and trying to remove every little speck of dead skin. We all have bit of dead skin and wax in the ear. It's all natural. So when the skin's easy to remove, we don't mind doing that. But all the little flecks of skin, that's fine. We'll be there all day otherwise, and it's not our job. It's not what we're trying to do. The patient at this stage, symptoms all but alleviated. There is some wax. You can see there on the left-hand side of the eardrum, the anterior recess. That's a very difficult region of the ear canal to get access to because you've got a bony protrusion there. So what I've done, the fine end, I've just bent it, and it just allows me to enter the anterior recess. Bit of dead keratin there. Again, we've got to be so careful not to make contact with the bony part of the ear canal there. But the eardrum's fully visible now. Just going back into the anterior, we're just going to be so careful. We just don't want to touch the side of the ear canal because that can be very uncomfortable for the patient. There we are. I've just got a bit more wax off there. There's a little piece of residual wax on the eardrum. It's not significant. You can see the bend there on the fine end a bit more vividly, just mopping up near the entrance. So I know this patient will be watching this on YouTube. He's a big YouTube fan, and he's given us permission to upload this. Now, this is the right ear, and it has been using a cotton bud. You can see on the wax there where it's been pushed in, where I've got the ear hook, you can see there's a mark there on the wax, almost like an imprint, and that's where the cotton bud have really pushed it in. The wax, again, is really, really dense. It's very thick, heavy, dense wax. And I kind of find sometimes the drops at this stage anyway, it won't really do much. Even putting the drops in will make the wax a bit oily, but it will still be quite a struggle to remove. So I'm just using using the Jobson horn here. You can see just how much pressure I'm having to use to kind of lever this wax out and extract it because it's that heavy and that dense. So, and again, we're just got to be careful with when we use these instruments. We don't want to we want to avoid wherever possible making contact with the canal wall. You can just see how heavy and dense that is. And I've just spotted a little gap there where I can just try to insert the Jobson horn through, getting behind, and as I'm pulling the Jobson horn out of the ear, I'm just trying to get as much surface area of the Jobson horn behind the wax. It's sometimes a bit difficult because when you've got wax this dark in colour, the Jobson horn it kind of can get camouflaged in behind the wax because it's a similar colour. You can see there, it'd be quite easy to lose track of where the Jobson horn is. It camouflages itself. A big piece of wax coming out there. Again, it's really heavy, dark wax. So we're just kind of funneling through the ear canal there. So I've just decided to see if because we're on the cartilage portion, I can just put a bit of pressure against the canal wall here, trying to loosen this impacted wax off the anterior canal wall. You can see all the skin adhesions there. I'm just lifting it away and getting in behind the lump of wax, and as I'm coming out I just want to get this piece of wax out of the ear canal, but there is a lot of skin adhesions that prevent it's kind of trying to hold me back. Nonetheless, I've got a big chunk out there. There's some residual skin that we've loosened and elevated off the canal wall. So I've just spotted a bit of a gap at the roof of the ear canal, and again we're just near the cartilage portion. I've just lifted that piece of wax down to give me more of an entry, but it's a bit difficult still because of the hairs, and I think I'm now going to go in with an ear hook which is a bit slimmer. And I just want to see if I can get in behind a bit further without trying to make contact with the canal wall. Got another piece of wax out there, quite a big chunk. And once more, just with the ear hook, because it is a bit thinner compared to the Jobson horn, so I'm able to glide it through smaller gaps. But Jobson horns, I've got to be so careful there. You can see I was very close to the roof of the ear canal, but I just managed to keep a steady hand and glide it through and bring this wax through. However, the wax at this stage, I think the Jobson horn's more slicing the wax than actually removing it. So just going back in with the Jobson horn, I'm just being really careful there. What the ear hook did do, although it sliced the wax, I was able to compress the wax a bit lower down, making that gap at the roof a bit wider and bigger so I can put the Jobson horn through again. So it's quite common that during a single procedure we use a range of instruments, and we use them in combination in support of each other. Again, just with the Jobson horn, just at the base, just bringing forwards and extracting another piece of large, dark, heavy wax. You can see all that skin that's kind of coating the wax. It's just on the anterior lateral canal wall, which is made up of cartilage, so we can put a bit of pressure there. So this stage, just gone back in with the ulnar suction probe, just trying to, again, you can see that all that dead skin that's coating the wax that was stuck to the canal, and just going around, all the way around the wax, just loosening these skin adhesions. I'm just going to bring all this wax to the middle of the ear canal, bringing it away from the ear canal wall. It's very heavy, and you can see all that dead skin there, all the way around the wax. If that skin wasn't present, or if it wasn't attached to the wax, it would be so much easier because there's less resistance. So I've kind of positioned all this wax into a big ball. It's all loosened all the way around the ear canal wall. Most of the skin adhesions I've been able to loosen. I'm just squeezing through with the ear hook, bringing this forward, just trying to not slice through it. And there we've got a huge chunk of wax there. But there is a lot more, and again, I'm just going to go in with the ear hook, trying to just avoid contact at all means with the canal wall. Back in with the ulnar suction probe, just going to loosen this again, bring it to the midline, bring it into the middle of the ear canal. Okay, I think I'm gonna, which instrument? I think it's in Jobson horn. There's a wider gap there, so ideally a Jobson horn is better for this type of wax because it's so dense. If the wax was rock solid, then an eel could be great because you just get in behind it, it comes out in a big go. But when it's a bit dense like this, it can slice through the wax almost like a knife through thick butter. So Jobson horn, because of its increased surface area, it can be sometimes more effective. But again, we're using the instruments all in combination to support each other. Again, just getting behind this dead skin, I have to be so careful there, as I wanted to avoid contact with the bony part of the ear canal. And I think in a moment I'm going to be putting some drops in, because now we're quite medial. It's a lot more difficult to use these instruments because it's coating the canal wall, and it's going to be very uncomfortable for the patient. So I'm just looking there, and you can see a bit of, you can see now I've put the drops in. So I've used sodium bicarbonate drops because sodium bicarb works a lot better with dead skin than olive oil spray. That's just my anecdotal findings. So loosen this. If I put the drops in before, it wouldn't have penetrated through that thick, dense layer of wax, and I don't think the drops would have been that effective with that outer part of the earwax. But now, because we're working more skin, the wax is less dense, although it's still quite thick, you can see there, but the drops is going to have more of an opportunity to penetrate this. If I put it at the beginning, it just wasn't going to seep through. And the idea is just to peel off this dead skin all the way around. You can see I'm really tugging at it. This piece is lodged. It's lodged in the isthmus. So as I explained in the first ear, the isthmus is a narrowing of the ear canal close to the eardrum. And this lump of dead skin, I would say it's more of a plug of dead skin than wax. It's just lodged, so we just have to wriggle it out. You can see we've got a big chunk out there. It's actually larger than the entrance of the ear, so I just have to really pull that through. So we're left with a thick layer of keratin coating the medial part of the ear canal, and this keratin is also coating the tympanic membrane, the eardrum. And at the top it's very fibrous. You can see how elastic and stretchy it is. I'm really suctioning that, and it's just holding on to the eardrum. It doesn't want to let go. Really tugging at it. You can see on the left hand side where the skin is still attached to the canal wall, you can see I'm trying to loosen it there. So I've gone in with the fine end now. I just want to approach the eardrum to see, sometimes when you suction the eardrum, the skin just comes off like a plaster. You can see it's peeling it gently there. But at this stage, when I was in contact with the eardrum itself just didn't feel like a normal eardrum. The majority of the eardrum, apart from the attic, the roof, is what we call the pars tensor, and it's got muscle fibers. It's obviously delicate, but it has some resistance. But when I was just approaching the eardrum there, the whole eardrum felt a bit wobbly. It was almost like a water balloon. It was like a sack of water. It just didn't feel right. So at this stage, I had some reservations. I had a suspicion that his glue ear may have returned in this side. And when you've got fluid behind the eardrum, it bulges the eardrum, and it literally turns it to, as I said, a balloon of water. It kind of sags in the ear. The eardrum becomes really saggy. And the last thing we want to do is puncture that during the procedure. There's a little piece of skin there. It's a long tail of skin there, which will come out in a moment once I've detached it from the floor, the base of the ear canal. And I can just see in the background the eardrum. When I was pulling this wax, I'm just keeping one eye, and I can see it is slightly bulged. So it's still got this thick layer of keratin, which is disguising what's going on with the eardrum, if I'm honest. But you just get this feel when you're removing it off the eardrum that it is a bit, as I said, a bit saggy. It's like a water balloon. This is one of the benefits of endoscopic earwax removal. We've got such a great field of view. I've got the whole ear canal in view. With other visualization techniques, so head loupes and microscopes, particularly with a microscope, you get a fantastic magnification, but you don't see the whole ear canal in one shot. So when you can see the whole ear canal in one shot, you can work around the ear canal. You know which part of the ear canal you need to work on to loosen the wax, and you can move on to the next bit. With a microscope, you're having to constantly reposition the patient to get the view that you want, and then you're getting all these different views, and you're having to mentally create a jigsaw piece. And just going to go back to here, you can see I'm just trying to remove this wax, and the eardrum's moving with it. You can just see the back of it, and I'm just at the top there, just trying to remove this keratin. But at this stage, I'm 100% sure. No, I've got to be careful now, because there's fluid behind this eardrum, and that's why it's bulging. And this skin it's not going to detach. If I try and continue too much, I might perforate this eardrum, and you can see the eardrum just move there as well. So it's the back part of the eardrum. I'm going to have a still image in a minute, but I'm just going for this top piece of keratin to see if I can remove that, because that's not where the bulge is. So I've just got the fine end, but that again, it is causing the eardrum to wobble. And sometimes we quit whilst we're ahead. If I persevere with that and perforate this eardrum, we wouldn't be in a good place. Now I've just labelled where the bulge is on the eardrum. I've got another video, I think it's number 194, where the eardrum is about to explode. I wouldn't say this is as severe as that, but there is a posterior bulge. There's all the contents. We did perform tympanometry. We did diagnose he had glue ear in the right ear, so we've recommended nasal decongestion spray and the Otovent nasal balloon. I've also made a referral to the patient's GP so we can get some antibiotics prescribed for him. And you may also need a second referral back to ENT given his history of previous grommets, because they may have to consider some